Good afternoon and welcome to our Neuroscience lecture series. I am Dr. Galit Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health International. It is my pleasure to welcome all of you to this informative presentation. I'd like to extend more warm greetings to our friends across Latin America and the Caribbean and everyone joining us today. During this interactive presentation, you have the ability to ask questions via the Q&A feature located in the bottom of your screen. I will be the moderator in today's lecture. This afternoon, I have the distinct pleasure of introducing Dr. Jason Liounakos. His presentation is titled Robotic and Spinal Surgery, State of the Art. Dr. Jason Liounakos is a neurosurgeon and the director of Outpatient Spine Surgery at Baptist Health Miami Neuroscience Institute. He specializes in disorders of the spine, and his clinical interests includes complex and minimally invasive spinal surgery, spinal tumors, degenerative spine disease, and spinal deformity. More specifically, Dr. Liounakos focuses on spinal robotics and advanced navigation techniques. He employs new technology and the latest minimally invasive technologies to reduce postoperative pain, speed up the recovery, and improve patient outcomes and satisfaction. Dr. Liounakos graduated from his class from the Florida International University Herbert Wertheim College of Medicine in Miami and received the Florida Board of Medicine Chairman's Recognition Award in 2015. During his residency in neurosurgical surgery and neurosurgical experience at the University of Miami at Jackson Memorial Hospital, he served as chief resident and obtained the highest score in the primary examination of neurosurgery board of the program's history, and upon graduation received the Sanjeev Bhatia MD Distinction in Leadership and Service Award and the Baptist and the Best Resident Teacher Award. He then went on to complete his fellowship training in complex and minimally invasive spinal surgery, also at the University of Miami and Jackson Health System. Dr. Liounakos is active in research and has authored numerous peer-reviewed publications and book chapters. He has lectured nationally on minimally invasive techniques and robotic-assisted spine surgery. He's the lead author of one of the largest case series evaluations patient outcomes following robotic-assisted spine surgery. Please let's give a warm welcome to Dr. Jason Liounakos. Dr. Liounakos, what a pleasure having you and meeting you for the first time. Thank you so much for your time and for accepting our invitation. The floor is yours.
Thank you so much for that warm welcome. I'm just going to share my screen here. You guys can see it, I believe.
Yes, we can. Yes.
Okay, perfect. So we're going to talk about robotics and spine surgery, state of the art. Oops. All right, I have no financial disclosures. And so learning objectives. So upon completion of this lecture, I'd like the participants to be able to describe the history of robotics in industry and medicine, identify specific goals of robot-assisted spine surgery and progression of technological innovation, and compare and contrast the different techniques for instrumentation placement and develop evidence-based conclusions regarding robotic utilization in spine surgery. So we're going to start off with history. So robots initially were used to revolutionize industry. Joseph Engelberger was the father of modern robotics, and along with inventor George Devol, brought the robotic arm to life. You can actually see Mr. Engelberger here on the right, and a very early robotic arm being displayed. In 1959, the first industrial robotic arm prototype was installed in a GM plant, and in 1961, the first mass-produced arm is introduced. Only a few years later, in 1969, robotic assistance has allowed GM plants to produce 110 cars per hour, more than double the rate of any automotive plant in the world. And that essentially revolutionized the auto industry, and everyone else quickly followed suit. The first surgical robot, interestingly, was actually a neurosurgical robot. They used a industry-based platform to actually do a stereotactic brain biopsy, kind of like what we would do today, but it's the first application. Here we see again Esquire magazine, and this was in December 1985. So what are the goals of robotic surgery in general? So we want to eliminate unwanted motion in surgery. We want to improve manual dexterity. We want to facilitate minimally invasive operations, allow for remote surgery, and provide higher quality patient care and improve outcomes, number one. So what kind of robotic systems are there? There's master-slave systems. This is entirely dependent on surgeon activity. This is essentially the robot that is very, very much used in general surgery operations and urological as well as gynecologic operations. Active systems, where essentially you don't do anything, the robot does everything. That's not really used in medicine. And semi-active systems, which require a surgeon-driven element to fulfill a pre-programmed task, cobot surgeries. And this is where spine finds itself. Now, in general surgery, robotics was born from the intersection of laparoscopy and remote surgery. Laparoscopy was great, but it did have weaknesses: 2D views, limited movement, limited ranges, degrees of freedom. And then, how can we build on that? And remote surgery, this is an idea pioneered by the Department of Defense, NASA, and these other organizations to treat, maybe if we need to do surgery remotely, say in space or on a battlefield. So over this evolution from 1993, the first general surgery robot came out. And over the course of, 10 years, this developed into a similar robot as we know today, with 3D optics, 4 arms, 7 degrees of freedom. And over the past 20 years, that's just been refined further and further. And that's in general surgery, urologic surgery, et cetera. Now, what about spine surgery? So robot-assisted spine surgery, we're currently focused on the guidance of pedicle screw placement. What's a pedicle screw, if you don't know what that is? When we do spinal fusion operations, we need to stabilize the spine. And in the thoracolumbar spine, we do that by placing screws into the pedicles and connecting them with rods. This is where computer guidance and robotics has really found itself for spine currently. What are the goals here? We want to increase the accuracy of pedicle screw placement, because what's just medial to the pedicles, the spinal canal with the neurologic structures, we want to keep those safe. We want to decrease complications along the same lines. We want to reduce the radiation burden that our surgeons are exposed to, and patients as well. Because oftentimes, traditionally, you'd either place screws either freehand with anatomic landmarks or with fluoroscopy, meaning X-ray. And that over time does translate to a high burden of radiation. We want to enhance outcomes. Number one, this is always at the core of everything we want to do. And we want to enhance manual dexterity and improve outcomes. Sorry, I said outcomes, but I meant ergonomics. So ergonomics in surgery, and number one is outcomes always. So what is the history of robotic systems for spine surgery? We saw a little bit about general surgery. So in 2004, FDA approval was obtained for the first robotic guidance system. In 2011, a second generation robotic guidance system received FDA approval. And between 2017 and 2019, multiple third generation robotic systems, primarily with neuronavigation, are released and are now being widely used. So who's interested in all this? I mean, there's a lot of interest by all stakeholders: patients, surgeons. Here we see I had several pictures on the title page, but there have been multiple special issues of peer-reviewed journals that are dedicated to robotics. Here's another one, and another one yet. And if you look at this is taken from a paper that looked at the utilization of robotics, and you can see that from 2011 to now 2021, just an explosion in the number of articles published. So there is a lot of interest here. Healthcare systems are obviously very interested in this for multiple reasons. And industry, the ones who make the robots, are clearly stakeholders here. One major company actually reported a 100% increase in enabling technology revenue in 2021 compared to 2020, and they owed that entirely to robotics. So the big question, though, is there value of robotic utilization technology for spine compared to conventional techniques? And what is value then? We think about quality, we think about cost. So what is quality? Quality is safe. Is it safe? Is it effective? And does that translate to improved outcomes? And then cost, is it cost effective against, compared to other techniques? I mean, that is a real consideration in today's day and age. So what's the data? I mean, here's the real meat and potatoes of this. What's the evidence for accuracy, for safety, for outcomes, and for cost effectiveness? And we're going to talk about this in detail. So what's the consensus? We'll start off with that. So the potential benefits of robotic-assisted spine surgery exist, but the literature is limited and heterogeneous. I mean, there are multiple studies that have come to this exact same conclusion. And why is that? Why is the literature limited? Well, the data in these papers suffer from primarily retrospective design. There are very few prospective controlled trials that look at robotics in spine surgery, and those that are done are not of the highest quality. Inconsistent methodologies. I mean, if you look across the board, you're either seeing papers published about MIS, about open surgery, different kinds of surgeries. I mean, when we're talking about robotics in the literature today, we're just talking about the placement of pedicle screws, but pedicle screws are placed in a very wide variety of operations with their own inherent risks and benefits and complication profiles. So it's hard to target, and many of the studies don't actually focus in. And then when you're combining them into larger studies, systematic reviews and meta-analyses, those limitations really come into play, and the conclusions can be biased. Small sample sizes. This is an issue. You know, the N is low, so that has its own issues in itself. There's heavy industry involvement. I mean, because this is, you know, a multi-billion-dollar enterprise, the industry stakeholders who build these robots are very keen to fund research, but then you have biases based on that. They, you know, lead you in a certain way, and that does not necessarily translate into the most sound scientific methodologies. And finally, you know, rapidly evolving technology with many studies utilizing quote unquote retired systems. So you look at these studies and, you know, if you do a literature review, I mean, you're going to be reading about robots in spine that aren't even used anymore. People are still writing papers about their series from when they had a first generation robotic system, and now we're all in the third generation system. I mean, is there a difference between the robots? That's a real question. And I'll talk about that in a second, but this is an issue as well. So here we go. Does the robot matter? They all kind of look the same. They all kind of do the same thing, but obviously they're proprietary. And do they work in the same way? Do they work as good? I mean, how does that work? And we don't really know. And the reason for that is there is no direct comparison between robots from different manufacturers. There's been only 2 studies that have compared different generations of robotic guidance systems. There's one study in 2021 recently where they compared navigated to non-navigated cohorts, including 372 total patients and 2,800 screws. What they found was there was significantly lower abandonment rate in the navigation equipped system. That would be the more recent system, and a shorter radiation time per screw. But they didn't find any difference in accuracy, time per screw placement, complications intraoperatively, length of stay, or 90-day complications. From the same group, they looked then at second and third generation systems. And again, similarly, they found there was a lower abandonment rate favoring the newer systems, substantially so, if you see these numbers here. Significantly lower S2AI, which is a type of pelvic fixation screw, favoring the new system. But again, no difference in accuracy, the time per screw, or the radiation exposure. So what's the summary of that? I mean, these are 2 papers from the same group, and there may be some cases in each one that are replicated in between the 2 studies. So we don't have a lot of good data, but there's a suggestion that there's improved reliability associated with newer generation systems. And I've seen that firsthand myself using the robots extensively. The older ones typically come with some more hiccups, and the newer ones, as you would expect, are more streamlined in their functioning. There've been improvements in planning software as well. But interestingly, the accuracy remains high between generations. And this is understandable. I wouldn't expect, if the accuracy was very low on one of these early generation robots, for it to have even received FDA approval. Now, let's talk about accuracy a little more. So how do you quantify accuracy? So the accuracy is essentially quantified by the placement. Is the screw within the pedicle? And there are different grading systems for this. And the best ones would be CT based. In general, you would want a grade A or grade 1 screw, which is completely seated within the pedicle. But multiple studies quote clinically acceptable as also including a less than or equal to 2 millimeter cortical breach. Now, there have been reviews that have looked at placement of accuracy in pedicle screws between different techniques. Here was a large study that found the overall accuracy of a clinically acceptable screw for freehand, meaning anatomic based, ranging widely from 69 to 94% accuracy. Fluoro, i.e. X-ray guided, even wider range, 28 to 85%, and CT navigation closing in that range, 89 to 100% accurate. So we do know, and CT navigation, we're not talking about the robot, just talking about general CT-based navigation. Now, this is from a paper that I wrote looking at, complication readmission rates for current generation systems. And we did a review of the accuracy of current generation systems. And these are basically, up till now, the only studies that looked at this. And accuracy is very high, 97.3 to 100%. Now, the accuracy compared to conventional techniques, what about looking at the robot versus freehand, fluoro, or CT navigation? I mean, there have been a couple recent systematic reviews that have looked at this. One recently in 2022 saw that robotic assistance was associated with less risk of inaccurate screw placement compared to conventionally placed screws, including those techniques, fluoro, freehand, and CT navigation. In a subgroup analysis, they actually found that robotic assistance superiority compared to each individual technique as well, including CT navigation, which is what a lot of people will talk about. Okay, well, do we really need a robot because CT navigation is so good? Now, looking further here, there's a second one in 2022 showing you how the interest recently in all this stuff, showing robotic assistance with significantly higher accuracy than freehand, fluoroscopy, and CT navigation, as well as optimal screw placement. Now, if you're just looking at current generation robotics, meaning the robots that are out, the most recent ones versus CT-based navigation, it's limited. And we're limited to retrospective cohort studies. One study in 2019 showed no difference between robotic assistance and CT navigation. Another study in 2020 from the same group showed increased radiographic accuracy with robotic assistance. Interestingly, another study saw no difference overall. However, if you look at grade A screws completely seated within the pedicle, those were significantly higher in the robotic group compared to the navigation group. But if you look at it overall, clinically acceptable, there was no difference. So another question is, does robotic assistance influence pedicle screw selection and accuracy in minimally invasive spine surgery? And this study basically found there was no difference in accuracy, but using the robot allowed for significantly larger diameter and longer screws. And so the question is, does robotics allow for the quote unquote optimal screw? But does that even confer a clinical benefit? And the answer to that is we don't know. A better screw, wider diameter, longer, increases the pull-out strength, but whether or not that translates to improved patient outcomes is uncertain and is not covered in the literature. So to summarize, robotic guidance provides a highly accurate placement of pedicle screws, at least equivalent to CT navigation, and may allow for the optimal screw trajectory to be placed. But is there a clinical benefit? We don't know. And of the literature we have, it appears that the older systems compared to the newer systems have the same accuracy, but there may be increased reliability associated with the newer robotic systems in spine. What about complication rates? This is what we all want to talk about now, because it also, aside from decreasing patient outcomes, increases cost. The cost for revision surgery for a malpositioned screw has been quoted at $24,000. So this is a significant burden on all stakeholders, the patient, because they have to go back through a surgery. Maybe they have a complication as a result of it, or a new symptom, and the healthcare system. Well, what about complications aside from just screw malposition? Here, the literature is extremely limited. In few studies, there's wide variability, small sample size, retrospective, limited follow-up, and the definition of a complication is not clear. In order to kind of look at that, we put together this large multi-center database of current generation robotic assisted fusion surgeries and found, we put together 800 cases, almost 5,000 pedicle screws. We wanted to define what the 90-day complication revision and readmission rates were for current generation robotic systems. So we looked at intraoperative complications. We also looked at a slew of postoperative complications within 90 days, things that haven't really been looked at. Here's some of the information that we got. About half and half, the robotic systems are navigated versus non-navigated. There's a 60-40 split between percutaneous, minimally invasive versus open placement of screws. Most cases were primary, and kind of a summary of the rates of these complications we'll talk a little bit about. So there was no neurologic or vascular complication as a result of a malpositioned screw at the time of the index surgery. So that's great. I mean, we really don't want those kind of complications. And all reoperations for malpositioned screw, interestingly, occurred with a non-navigated system. Navigated robotic system, no instances of postoperative screw revisions. So in summary, there was a 0% intraoperative implant-related complication rate, 16% incidence of overall incidence of postoperative complications, including everything, less than 1% chance of return to the OR for screw repositioning, but 0 in the navigated cohort, and revision rates similar to what has been discussed in the literature already, compared to the literature. There have been several other systematic reviews that have combined or looking at differences between the robotics and conventional techniques, but the overall included study quality in these systematic reviews is overall poor. And this one study in 2019 wasn't able to make any conclusions regarding complication rates for robotics as compared to other techniques because of a sheer lack of data. That's kind of just showing that. I'll breeze through this. This is kind of more of the same, a 2021 systematic review. They did actually find that robotic systems associated with decreased complication rates, revision rates, but similar blood loss and length of stay. Finally, in 2022, most recent systematic meta-analysis looked at almost 80 studies, 23 of those addressed complication rates, and they found a higher odds of complications associated with freehand guidance compared to robotic systems, but no difference between CT navigation and robotic assistance. So summary, complication-wise, implant-related complications are low, but pooled analyses suggest lower rates of revision surgery in robotic-assisted operations, particularly with respect to implant placement. But no significant conclusions can yet be made as to whether robotic assistance independently confers a meaningful benefit over conventional techniques with respect to complication rates, just because of significant biases and limitations in the literature. We're going to kind of go through this quickly because we're running short on time. Another very important thing in medicine today is looking at patient-reported outcome measures. These metrics are crucial to understanding the impact on overall patient well-being. There's extremely little data available to evaluate any potential impact of robotic association on patient-reported outcomes. Very few studies, most of them are industry funded, and there's significant differences between comparator groups. The data that is available suggests that there is no difference in PROMs at long-term follow-up. Here's one study looked at a retrospective cohort evaluating 1 year PROMs of robotic assistance versus freehand fusions of 1 to 3 levels. No difference in complications or revisions. No difference in the change in any of these patient-reported outcome measures. So they concluded that procedure type is not an independent predictor. So what about cost effectiveness now that we talked about quality? Well, few studies provide any actual cost data related to robotic assistance in spine surgery. There's only 2 published cost utility analyses, to my knowledge. Here's one that did some cost modeling looking at robotic assisted minimally invasive spinal fusion versus navigated spinal fusion. And they actually did find robotic assistance to be more cost effective by about $800. They didn't really go into the reasons for that, however. There was a shorter length of operative time, but it was not statistically significant. This other study looked at 120 open, 120 minimally invasive, and 120 robotic assisted surgeries. And they found, interestingly, again, going back to the heterogeneity between the literature, there's significantly higher post-op complication rate in robotic assistance compared to MIS and open surgeries. They found, as a result, robotic assistance was associated with 30% increased cost. And most importantly, in neither of these studies is the cost of robotic acquisition taken into account, which, as you can imagine, is quite steep. So is there value? Well, quality-wise, we know it's highly accurate, at least equivalent to CT navigation. Pooled analyses suggest there may be an advantage with respect to complication revision rates, but individual studies are low quality and there is conflicting data. In improvements in patient outcomes between robotic assistance and conventional surgery are similar. Cost, there's limited conflicting data precluding an evidence-based conclusion. So essentially, we don't know is the answer to that. So how can we further elucidate this quality question? We need better studies, higher quality prospective, ideally randomized studies comparing similar procedures with and without robotic assistance, an increased focus on patient-reported outcome measures, as is being very commonplace in all fields of medicine today. Increased focus on cost effectiveness, considering the cost of acquisition and disposables, which is substantial. And finally, the effect on variability of operation length. This is something I'm interested in, looking at, if you can standardize procedure time. I mean, everybody, surgeries take different amount. The same kind of surgery always takes a different amount of time because everybody's anatomy is different. Everything is a little bit different. So you can have a surgery that typically takes you 2 hours, take you 4 hours or 3 hours. What if robotic assistance could help to standardize the length of surgeries? Then you could improve your planning in the OR. You could do 4 surgeries in a day instead of 3 instead of 2, and better utilize the systems that are in place. So I find that very interesting, and I feel like that's the future of research. Future speculation for robotics, where are we going? I do think we're going to see an increase in utilization across the board for robotics and spine surgery. And I think that we're definitely going to see an evolution beyond just pedicle screw placement. We're going to start seeing the robot being used for decompressions, doing complex osteotomies for scoliosis procedures, and integration with planning software, which we're already seeing to get the best result, before even stepping into the operating room. And we have some studies there. So in summary, robotic assisted placement of instrumentation is extremely accurate. Whether this translates to clinical superiority compared to other techniques is unclear at this time. Pooled analyses acknowledge the potential benefits of robotic assistance in spine surgery, but the validity is limited by multiple factors. But what we can say is there's a suggested improved complication and revision rate profile compared to conventional surgery. But again, we need better studies. There is significant interest by everyone in robotics and spine surgery, and this interest will likely fuel higher quality research in the coming years focused on patient outcomes, and I think that's where we're going. Here are all my references. I think we finished in a perfect amount of time.
You sure did. That was amazing. It had to be a neurosurgeon to actually time himself that way. Thank you so much, Dr. Liounakos. What a
My pleasure.
Recap and presentation on robotics. This has always been somewhat of a mind-boggling area for many physicians, especially since the advent of new technology is coming. Before, nobody thought that now neurosurgeons will be using robotics. I mean, we obviously heard of Da Vinci, and we know that we have a great center of excellence for robotics, and we use it extensively in abdominal surgery and the like. So that really constituted like a revolutionary measure at the time, when we started with the robots instead of laparoscopy. And suddenly insurance companies start arguing, well, robots are not necessarily the way to go, and we cannot necessarily reimburse. And Baptist took the stance and said, you know what, we're going to get reimbursed just as if it was a laparoscopy. So chill out, just reimburse us for it. We have no codes at the time. And now look, almost 80 to 90% of the surgical procedures in abdomen we perform it through robotics. Aside from you, because we will come back to you in a second, even in orthopedics, now we hear that the Mako device for knees are widely utilized and used. So it is absolutely outstanding. So one of the things that come to mind is obviously, aside from the incredible quality outcomes that you get, is those questions that not only physicians that practice the traditional or the ways of actually performing the surgeries that you are accustomed to doing now in robots. Patients do tend to have very similar concerns or questions. And how do you determine the use of robot versus an open procedure or laparoscopic procedure per se?
Well, it's a good question. And it depends what you're trying to accomplish. I mean, as it stands in spine right now, the robot is used to place instrumentation. And when can that be useful? That's most useful if you're doing a very large surgery where you're placing a lot of instrumentation, because the efficiency, the time, the savings of time per screw placement really add up at that point. Also, though, in shorter operations or shorter segment fusion surgeries, where the patient has very complicated anatomy that is not straightforward, then it can be very useful. As the planning software for these robots gets better as well too, you can actually, if you're doing like a deformity operation or an operation for scoliosis, you can plan your screws before you even step foot in the operating room, in a way that that they're going to line up. You can even plan osteotomies and bone work to get different corrections and see what kind of correction you're going to get before you go in there. So there is a lot of stuff that can be done before you even step foot in the operating room. And then once you get in there, you've got the plan, you take care of it. Time savings is key there, because in these bigger operations, time equals blood loss, and increased anesthesia, and thereby potentially increased morbidity as a result. So it can really, really be helpful because that's the hardest part. I mean, in those kind of operations, the hardest part is deciding what exactly you need to do at the time to get the correction you want, and then making sure everything works seamlessly, including putting the rods down and stuff like that.
Mm-hmm. So would it be safe to say that the great percentage of the scoliosis patients are dealt with in robotics, or you still need to open?
Well,
understanding caveat, right? Understanding that each anatomy is completely different.
So it's actually, very different between the way we look at robotics for general surgery with the Da Vinci robot, for instance, and in spine, because if you think about what the general surgeons do with the robot, is they're operating in a space that's kind of expanded. They fill the area with gas, just like in laparoscopy, and they're moving around doing everything through these little incisions. The spine is different, because the spine, there is no potential space. You're basically just going through the muscle and the soft tissue, and you're there. So you don't have that maneuverability. So you can use the robot either to drop minimally invasive screws, or if you're doing an open operation, you can use it to place screws in the open setting as well. Not everybody has a robotic guidance system. So I would not say that the majority of these operations are being done with them. But I think more and more as centers are adopting robotic platforms for spine, they're going to be using them in these big, long operations.
Mm-hmm. Mm-hmm. In regards to scoliosis, patients with scoliosis, do we still consider that those surgeries need to be performed at early in the adolescent kind of life, or can we still think you can always have it at the later stage, meaning 80 years old or 85 years old, and so on?
It really depends. Scoliosis is a very interesting subject in spine surgery, because the kind of scoliosis that you get as an adult is very different than the kind of scoliosis as a child. And I personally am not an expert on adolescent scoliosis, but essentially the pediatric surgeons spine surgeons who treat this are looking at changes in the scoliosis over time. And if things get to a certain point, they say, okay, well, we need to fix this. I mean, if it's a minor scoliosis, oftentimes that's never treated with surgery. But if it's a significant curve or a curve that's worsening, then they'll treat it. And that kind of scoliosis is typically not saved until later in life. Now, adults, like, typically 60 years of age and older, will develop adult deformity. And this is very different. This is essentially based on, I say to people who aren't in medicine, essentially all this that's going on is arthritis. That's the easiest way to understand it. I mean, it's a simplification, but it's all arthritis. And as a result of that over time, and the laxity and the ligaments and this and that, what ends up happening is people start falling forward. And you see these people that have these older people that have these kind of hunched deformities, or they're forward and they have to use a cane or a walker because otherwise they can't stand upright. And once somebody literally can't stand upright, or they can't even get out of bed, then you say, okay, well, this is an operation that we can do to kind of correct that. And what we call that is sagittal malalignment. So they're very different, but I don't know if the robot will change the way we decide who gets surgery and who doesn't. But I do think it is improving the way that people who are getting treated are recovering after surgery and stuff.
In comparison to the traditional way of doing it, not necessarily using the robot, because obviously those techniques are still used widely in different parts of the world. What is, in comparison to the techniques that you use, the length of stay? How long do you anticipate a patient, again, depending on all the comorbidities, of course, but typically, how long do you anticipate the patient to stay with you in the hospital?
It depends entirely on the kind of surgery that you're performing. And this is a reason why the literature for robotics is limited, because, there's some papers that are comparing somebody who had a 1-level minimally invasive fusion to somebody who just had like a 10-level like adult scoliosis operation. But in my what I see is, in general, if you're having, and I like to rely on minimally invasive techniques as a bulk of my practice, 1 or 2 level minimally invasive decompression and fusion, you should expect, at least for a 1 level, you should expect potentially 1 night in the hospital. Everybody is different, but usually 1 night, maybe 2 nights, 2 nights for a 2 level, something like that, and then home. As compared to if you do it open, if you did a 1 or 2 level open surgery, now you're talking about leaving drains in, you've done a lot more muscle dissection, there's a lot more post-operative pain. And now we're talking like 3, 4, 5, kind of depends, maybe even a rehab stay, inpatient rehab stay. So I tell patients who are having open surgery, there's 3 boxes we got to check for you to go home. 1, your pain's got to be controlled by medication by mouth, because you can't go home and have a pain crisis. 2, we got to get the drain out, and usually that's there several days. And 3, we got to have you up and walking around, like at least to kind of take care of yourself, understanding that you've just had surgery. And usually if you've done a big open operation, that's going to be much longer than if you do something targeted and minimally invasive, where we're really trying not to disrupt the soft tissues as much.
That is quite remarkable. We have 2 more questions and we'll let you go. I know you have had a really long day today.
It's all good.
The doctor just came out of a surgery and he's still gowned from surgery. So thank you so much for doing this for us. Dr. Chacon says, great presentation. In your opinion, does robotic approaches far better or different than the endoscopic approach? I think we touched upon that for a bit, but any final comments in regards to the differences?
And endoscopic specifically?
Endoscopic approach.
So endoscopic is another field in spine surgery, which is very interesting. And I was fortunate to train in my residency and fellowship. Now, endoscopic is kind of like the ultimate in minimally invasive surgery. I mean, we're talking about an incision smaller than, the tip of your finger, and, a camera going in and operating through that. It's limited. The things that you can do endoscopically, and while people are doing amazing things endoscopically, like getting disc herniations out and even doing laminectomies endoscopically, it really is extremely operator dependent. There are some like world authorities out there who only do endoscopic, and it's amazing what they can do through this small space. I think for in general, it's going to be very different. I mean, usually, actually, and what we were doing was we actually combined endoscopy and robotics, and we were doing minimally invasive 1 and 2 level fusions with the robot and endoscopic decompression. And, we saw great results with that. So you can combine the technologies, but I don't think one is a replacement for the other.
There's one of the consumers is asking, is degenerative spine disease and spinal stenosis considered as part of the robotic surgical program?
Absolutely. When I said earlier how, in adults, a lot of the issues that happen with the spine are related to arthritis. Degenerative spine disease is that essentially, and that results in stenosis and compression of the nerves and pain in the back and the legs. And, oftentimes, you don't need to do a fusion surgery to treat that kind of thing. You can just decompress the neurologic elements and patient's symptoms get better. If there is instability, meaning the bones moving one on top of the other, or there's a slip of one, or it even moves in extreme cases, then we start thinking about doing fusions. And yes, in that case, if you're going to do that, 100% the robot is indicated for that.
That's wonderful. How fascinating. You guys are just like in this environment that we all look up to. So thank you so very much for everything that you do for our patients and for our Neuroscience Institute. It's honestly remarkable. And the future for you guys and the new center that we're trying to develop for you guys, it's going to be absolutely the way to go for patients. So we're looking forward to more. I'm going to let you go, Dr. Liounakos. Again, on behalf of our entire team at Baptist International, thank you for incredible presentation. And to all of you that participated and attended today's lecture, please remember this lecture is recorded, so you can always request to view it at a later time. If you have an additional question or you have any concerns or you would love some kind of response to any of your concerns or questions, please send them to BHIWebinars at baptisthealth.net. That is BHIWebinars at baptisthealth.net. We'll make sure to send them to Dr. Liounakos for his response. And to all of you, we look forward to seeing you at our next Neuroscience lecture series, which is scheduled for Wednesday, April 26, 2023. Thank you once again and have a phenomenal afternoon. Thank you so much, Doctor.
Thank you, guys. Thank you for having me. Take care.
Yes, anytime. Bye.